I mean, obviously, from the double-blind studies and the studies that SK Pharmaceutical Company, those were all as adjunctive studies. I think we'll probably see more and more people coming down to monotherapy, reducing their drug load, because clearly more people stayed on the cenobamate when we lowered the concomitant medications. And patients overall want to be on reduced medications. Patients not only talk about I'm on 1, 2, or 3 drugs, but they talk about I'm taking 20 pills of this and 3 pills of that and 5 pills of that. I can't even fit them in my pill box. So I think we're hopefully getting more and more people controlled with their epilepsy. I think that makes a big difference in people's lives. I think it helps them from an economic point. It helps them from a quality of life point. When we truly start getting patients 75% and better in their control, and clearly when we get 100% reductions, we make the biggest difference in people's lives, whether it's driving, whether it's just feeling safe, walking across the street, or doing things that a lot of us take for granted. And so it really is helpful. It helps for employment. I see the drug doing very well in terms of that. I see that to me, it's a drug that I've known for 10 years already. So it's not an early drug for me, but it is an early drug for me. In other words, many people say, well, I try it on my worst of the worst patients. Well, for most people, when you talk about worst of the worst, you'll do twice as good for the patients with less intractable epilepsy. And there were some studies that showed that in terms of I think Sean Stearns and Dr. Wexler's papers that talked about the fact that the patients with less intractable will do extremely well. And so for me, it's an early add-on. It doesn't have to be the 8th, 9th, 10th drug that you utilize, but I expect that it will move up in the armamentarium as people get more and more used to using the drug. And I think another thing that'll be of interest over the years, maybe to see in terms of surgical patients. We did studies that we presented last year at the Academy of Neurology. Dr. Abu Khalil wrote the paper on that, where we found that many patients who had surgical had failed previous seizure surgeries, whether it was temporal lobectomy, frontal topectomies, VNS, a few RNS, had done very well in that 20 to 35% seizure free. Maybe not quite as much as somebody who didn't have seizure surgery, but still pretty good numbers. And so if you look at that, to me, I think it's probably going to be a drug that should be at least one of the drugs considered before most surgeries, at least, because it has such good numbers in terms of it. I think just overall, when we, the goal is to help the patients with least amount of problems. Obviously, surgical can do very well with patients, but there's still risks that get involved. And if you can get the patient controlled with medicines first, without surgery, even better. And so I think that's another aspect that we looked at. We also looked at some things with the elderly patients. The elderly patients actually had even higher results in terms of seizure freedom than younger patients. So that's one thing to consider. They had a little more side effects in terms of dizziness and falls. And what we learned from that was when we did that, when they would have any of the dizziness or falls, it would usually be at a high dosage, somewhere around 260 milligrams a day. So I think that what we learned also was that for the elderly, as they have decreased creatinine clearances, we probably should only aim for maybe at the top end, maybe 200 milligrams, because the drug is still metabolized in the liver and excreted through the kidneys. And as we have decreased creatinine clearance as age goes, we need a little bit lower dosage. We don't need to go quite as high. And that was also seen, I think, in the paper by Dr. O'Dwyer there.